does projects and accomplish things themselves, rather than giving the others the satisfaction of being leaders and making a difference. So that's how you can tell if your peer worker is doing what they need to be doing using the evidence-based best practice of the helper therapy principle. Another one is empowering others. And empowering others, the peer worker listens for and implements participants' suggestions, such as having a Kwanzaa celebration, writing their legislative representative about something they want changed, starting their own business, putting on a program, inviting people to a recovery panel, et cetera, et cetera. The peer worker lets the person help the peer worker. The low recovery is the only opportunities to help are those created by staff and or directed by staff. The peer worker sees their role as helping the person and rarely lets the person help them. Okay, so that's the helper therapy principle. If you've got questions about that, you can put them into chat and we'll address them as we move on, okay? And the same thing, put questions in chat and Painice will let me know when they're coming, okay? All right, the next evidence-based peer service is peer listening and disclosing. So the definition of peer listening and disclosing is using active listening techniques and sharing one's own lived experience of the situation a person is going through. Do not give suggestions or advice unless specifically asked for it. Peer listening and disclosing is different from and complementary to clinical expertise because it represents a relationship of equals in which each is benefiting from the relationship with the other. The key components to peer listening and disclosing are peers help others with similar challenges by understanding and sharing their own experience with I statements. Peers listen fully the whole time the person is talking without thinking about what they might say in response. Now, there's a really good study that was done on this where they discovered what they called the gist point, where people listen up until they think they've got the gist of what's going to happen or what the person is saying, and then they start thinking about what they want to respond to it, and then they listen again towards the end of the person talking, and they think they've gotten what the person has said, but in fact they haven't. So only after a person stops talking does the peer respond, and it's okay to have a few seconds of silence to gather thoughts. And of course, if you listen the whole time and gather your thoughts and then respond, you're going to have a much better communication than if you anticipate what the person is saying, which may or may not be accurate. Peers disclose only those parts of their stories that speak directly to what the person has shared. So it's not okay to start disclosing, telling my whole story when it's not relevant to the person I'm talking to. I need to find the things in my story that speak to the person who I'm listening to and disclosing to. Okay, oops, maybe I'll skip the video because I forgot to enable my thing. Okay, so now we have another chat opportunity, which is to describe a situation in chat where someone disclosed to you their experience that helped you feel better about your own, okay? So take a minute to describe a situation where someone disclosed to you their experience that helped you feel better about what you were going through. And Painice, if you can read when they come up, that would be great.
Okay. And we are getting a few requests if we could just move the slides a little more slowly, but I do believe the slides will be made available, Ruth, after your presentation.
Yes, all of the slides will be on the SHARE website for you to have, so you don't need to take notes.
Okay, and from Stephen. Hello again, Stephen. He's a new student of ours. I bit of his own struggles with mood. It really helped me feel comfortable with him.
So somebody shared their struggles with mood, and it made him feel more comfortable.
Yes.
Felt better because of it. There you go. That's exactly what this listening and disclosing is about. Do we have any others, or are we done? Or am I not giving people enough time?
My first peer support experience was reading Dr. Kay Redford Jamieson's book, quote, A Quiet Mind, unquote. I lost my mom in law last year. I was very close to her. Someone shared how losing their sibling had really affected them. I felt better knowing I was not alone.
There you go. Exactly.
One of my grad school colleagues disclosed her mental health diagnosis after I shared about my own, and it made me feel I was not alone.
And we feel better when we're not alone. Loneliness kills.
I met a single mother who shared that it took them 10 years to graduate with their BA. I felt less sad about only taking 2 classes a semester.
There you go.
A peer in a depressed state complained going to self-help meetings made them more depressed. I had a similar experience and was able to share specific self-help meetings that made me feel better.
Great. Okay, so do you have more, or
We've got one more. My supervisor shared feelings about being on the learning curve. I was relieved because I always had unrealistic expectations of myself.
There we go. Disclosure helps.
In gaining vision through harm reduction, workers, I learned that I was worth saving.
Yes, you are definitely worth saving. Please never feel that you're not worth it. You are worth it. We are worth it. We're all worth it. Okay, so peer listening and disclosing evidence. So peer listening and disclosing increases self-esteem and confidence, feelings of control and the ability to make life changes, the sense of hope and inspiration, empathy and acceptance, engagement in self-care and wellness, social support, social functioning, empowerment scores, and the sense that treatment is responsive and inclusive of needs. And this is off of SAMHSA's website, so you can find that when you get the slides, you'll be able to find all of that. Okay, the peer listening and disclosing key question is your listening free from judgment or suggestion? Or are the peers you're supervising, is their listening free from judgment or suggestion? Are you or they regularly sharing their own similar experiences in a way that the person they're supporting feels connected and hope is empowered to experience growth and change? So this is how you figure out whether your peer is doing what they need to be doing or whether you as a peer are doing what you need to be doing. Okay, so we have the high recovery and the low recovery of peer listening and disclosing. High recovery The peer worker discloses their experience with similar issues, including how they felt, what they thought at the time, and what worked and did not work without being asked. They use I statements in disclosing. The low recovery is where the peer worker discloses only when asked and does not include their feelings and thoughts at the time. They express their experience in the form of advice or say things such as, you should do what I did. Okay, and so that's one example of figuring out. Disclosing reality. Okay, high recovery is the peer worker discloses both their successes and challenges, including current challenges they are encountering in their recovery that relate to what the person is going through. The low recovery is where the peer worker only discloses their successes and appears to be perfectly recovered without any problems. They hide their own setbacks, both in the present and the past, from the people they're serving. So that would be low recovery. Another one is whether they're doing things peer-to-peer. So high recovery is where the peer worker is open about their lived experience, treats the person being served as an equal, and uses peer boundaries. The peer worker concentrates on connecting the person to non-paid social supports in the community. Okay, so non-paid social supports are natural supports. So that's friends, that's, you know, being member of a faith community, being a member of a club, doing activities that people like. Those are the non-paid social supports. The low recovery is where the peer worker provides support using a clinical approach and/or clinical boundaries. The person's social network is limited to professional relationships and other people at the clinic, so that they don't have anyone outside of the mental health setting who are providing natural supports in the community. That's the low recovery one. Okay, so now we're on to recovery planning and evidence-based best services there. Okay, so the recovery planning definition. Recovery planning is a way for a person to take charge of and control their recovery process by developing a written plan to help in their recovery. There are two main recovery planning tools. One is the Wellness Recovery Action Plan, or WRAP, and I think most people are familiar with this. If you're not familiar, we can give you some places to become familiar with it, but it's well out there, so I'm not going to go into it in great detail today. And the other is the SHARE Plan for Success. So let's start with WRAP. Is a self-designated prevention and wellness process that anyone can use to get well, stay well, and make their life the way they want it to be. Okay, and WRAP is effective. It's been linked to significant improvements in self-reported symptoms, recovery, hopefulness, self-advocacy, and physical health. It's also listed, or was listed until SAMHSA was required by the present administration to take down their National Registry of Evidence-Based Programs as part of the de-scientification of the federal government, but it was listed on the SAMHSA National Registry of Evidence-Based Programs and Practices because of research showing it works. Okay, and it's not that the research stopped working, it was just that they didn't want science on any of the websites anymore. Okay, so that's WRAP. The SHARE Plan for Success creates a pathway from today to success in 5 years using backwards design. Okay, in backwards design, you start where you want to be in the future, say 5 years from now, and you work backwards to get where you are today. Backwards design is an evidence-based best practice that's effective in helping people achieve their goals faster. And this is used in business all the time. As you figure out where you want to go, and then you figure out what your points in between are. So let's give you an example of a share plan for success. Okay, so the 5-year goal here was living in Hawaii in a beach house that I own, working as a real estate agent. That's what they feel that would make them feel successful, that's what they want to do with their life. Okay, so where do they have to be in 4 years? In 4 years, they have to sell houses in Hawaii, saving all their commissions, and sell their condo and buy a beach house. That's their 4-year goal. Their 3-year goal is to move to Hawaii with all their savings, buy a cheap condo to live in, get a Hawaiian real estate license, and start selling houses. Their 2-year goal is to sell 20 houses in Los Angeles and to save as much money as they can. Their 1-year goal is to get a job at a real estate agency and begin selling houses, saving every penny they possibly can. Their 9-month goal is to take the California real estate exam so that they can get a license. Their 6-month goal is to get a supervising real estate broker to sponsor them for their real estate license. And their 3-month goal is to finish real estate school. Their 2-month goal is to research real estate brokers to find one likely to sponsor them. Their 1-month goal is to continue at real estate school. Their 2-week goal is to start real estate school. Their 1-week goal is to fill out and submit a real estate school application. Their goal for tomorrow is get the documentation needed for the real estate school application. And what do they need to do today? They need to research real estate schools in Los Angeles and pick one to apply to. So you see, by working backwards, you then have a plan of how to do it going forward. And that's what backward design is, which is an evidence-based best practice. And we're so used to clinicians asking the question, what are your goals? And everybody's goal is what they want to do today. And we don't think about the long run. And the long run goals are going to address the goals, are going to take care of everything that they want to do. I once did this process with, we had a contract to move people out of board and cares who didn't need to be in board and cares, so we could move people out of state hospitals and other locked facilities into board and cares. And Cher got this contract, and we did a workshop with the Cher Plan for Success. And I had a guy whose goal was to work in a 7-Eleven so that his mother could be proud of him. And so we went backwards with the things that he had to do in order to do this. And when we got back to what he needed to do today, he stood up and pounded his chest and he says, I need to stop drinking, and it turned out that his goal was achieved in 8 weeks. He had a job, he stopped drinking, he got himself together, and he had a job working in a 7-Eleven, which made his mother very happy. And he achieved that. And of course, he moved out of the board and care, and the other people in our workshop also moved out of the board and care. And our funding, the board and care operators complained to our elected officials, and we were told we weren't allowed to talk to them anymore, talk to the people in the board and cares anymore. Oh, that was the contract we had. So this is a very effective tool, and I hope that you'll use it. So the way you use it is you have to discover what successful means for you and for each person. So let's do an exercise right now. Let's everybody, the idea, they say take a deep breath, but it turns out that most of us are holding our breath. So you need to exhale fully before you take a deep breath to have it the best. This is evidence-based as well. You need to exhale fully to take the best deep breath. So let's exhale. I'll read this to you and you can do it as we go along. Exhale fully. Close your eyes. Inhale. Now take 5 more deep breaths, exhaling fully each time. Now imagine 5 years from now when you are successful. What are you doing? What makes you feel proud? What is worth celebrating? What makes you feel good? What makes you feel accomplished? Dreaming, what would satisfy you in terms of being successful? So this is not becoming a billionaire. This is what would satisfy you if you become successful. And then we're going to give you the opportunity when you have that to write it down in chat for us. So write what your success would look like to you in 5 years. So Pinese, are you getting success?
Yes, we have one, owning a home. Or did you maybe want them to just read them, to speak them, or did you want them written?
Apparently the best practice is to have you read them.
All right, we've got owning a home, losing weight, owning a larger home, being successful and content, moving up in my agency, being retired. I'm gonna close my door. Running a program that is for children at risk of ACEs, building resilience. Another one is living in self-acceptance. Another, sustaining healthy habits to allow me to keep serving.
So these are very general ones. Usually we try for more specific ones so that there is a path to get to them.
And they're asking also, Ruth, if you could go back to the slide that has the question again. It's up, everybody. Write what success looks.
Yes, like to you in 5 years. What would you be doing? Where would you be living?
And someone has, Linda says, getting to keep doing what I'm doing today. Next, we have consistent happiness. My college degree and having a bigger home for me and my daughter so I can get her a dog and we won't have to stop for every dog in the street.
So that's a very concrete one. And so that's one where we can build backwards from that. Okay, so at 5 years, we'd have a house with a dog. So at 4 years, we need to have what done? We need to have the down payment ready and we need to have our credit in order, right? In 3 years, you know, and maybe actually that could be even earlier than that, but we'd be picking the dog at 4 years. To be in the house, we may have bought the house before that. And we just need to go backwards, finding out what we need to do, okay? Are people getting this?
Yeah, we have a couple of more. Rebranding our agency. I want to expand my program through MHSA funding.
Okay, that's a really good one. So, you know, coming up with a goal of how much funding you'd want at that point and what would the programs be? And then working backwards from that to figure out, you know, what's the easiest program to, you know, figure out which are the easiest programs to get started so that people can see your success rate. And when they see a success rate in one program, they'll give you money to start another program or one that they might not have the same vision on that you have on.
Okay. Another participant is saying, I need to get a financial degree.
Okay.
And then there is a request to go to a previous slide that had a few questions on it.
This one? And again, all of these slides and the plan for success itself, where we have it all written out for people to do, you know, it's a two-sided piece of paper where people can read it out. If I stop sharing this, will I be able to get back to it?
No, I think this is fine. This is what they wanted to see.
This is what they wanted to see. Okay. And the plan for success worksheet will be on the website. Okay.
Another plan I have here is build a peer-to-peer workforce for my resilience building program.
Oh, that's an excellent one. Okay. So that's the 5-year goal, is to have a peer-to-peer program for the resistance. I don't get to see the chat here, so sometimes you're going to have to help me with the words. Pinese, what was it?
I hope you come with the code.
I didn't get that either. So anyway, you basically do your backward design with it. That's how you're going to get there, is break it down going backwards as to what would be happening a year before you actually got to the place that you feel good about it. We've been doing this at Share for years, and we've added $1 million to our budget over the last 3 years, each year, because of our backwards design planning. So this is a very effective way of doing things. Okay, so the other thing about the plan for success is that once I have my my plan of what I'm going to do, I need to make commitments, daily commitments, weekly commitments, or monthly commitments that are made to a friend, a peer worker, a case manager, or written down share them with your self-help support group. If you share them with somebody, then you're much more likely to get them done. That's also evidence-based practice. There's no consequence for not keeping a commitment, but lots of praise for the progress. And often people need to test that, so they won't keep their commitment the first couple of weeks, and you just need to ignore it and ask them if they want to make another commitment going on. And then once they trust that there's no punishment for not achieving their commitment, they can go for further. Also, reframe attempts that did not work as learning opportunities rather than failures. So, and the other thing is that the plan is workable. So if all of a sudden there's a request for proposals that comes out that totally meets what you want to do in 5 years, you know, sure, change your plan to apply for that, because it makes sense in terms of your, you know, you got to keep your eye on the prize, as they say. Keep your eye on that final goal and see how you're going to get there today and use those opportunities to do that. So what we found is that most people achieve their 5-year success in 2 to 3 years. That once they have a plan, it happens rather quickly as they see the steps that they need to take. And they really can be baby steps in terms of researching, you know, what sort of education do I need to do what I need to do? How do I get into school? Where am I going to get a reference from? Things like that, that people are doing, okay? So in recovery planning, we have high recovery. This is modeling success, is where the peer worker shows their own RAP and plan for success with their goals and commitments and talks about how it has helped them. They also talk about things that did not work out as planned and how they coped with them, what sort of learning they got from that. The low recovery is the peer worker gives someone the forms to use in recovery planning, does not disclose their own recovery planning process or difficulties they've had to overcome or are still working to overcome. So as a supervisor, you can see whether or not they're doing this in an effective way or not. The next key ingredient of recovery planning, and again, there are many more of these in that will be in a handout that I will try to put to the chat after I can get off my screen here so that you guys can get that as well, but it will also be on the SHARE website. For support, the high recovery is the peer worker encourages the person to be ambitious and accepts the goals that the person wants to work on, even if they appear to be unrealistic, okay? It's really important not to say, oh, you're never gonna do that. You know, if it's an unrealistic goal, let the person discover that themselves, or let them find out what the essence of the goal is that they're going to be able to do. You know, I had one person once, we're in Los Angeles, so they were going to be a billionaire producer of movies in 5 years and living on a tropical island that they had bought in the Pacific, okay? That was their 5-year goal. Well, they had to learn themselves that that was an unrealistic 5-year goal. Maybe it wasn't. I don't know where they are 5 years later, though I haven't seen their name pop up on the billionaire list, okay? The low recovery is the peer worker who tries to make sure that the person's goals are easily achievable and realistic to where they are now. And hygiene should never be a goal. Good hygiene should never be a goal, because that comes along when people get self-esteem. We don't have to list a goal for that to happen. It will happen on its own when people get self-esteem because they're helping others and because they have a plan to get better. Okay, another effective ingredient of recovery planning is autonomy. So the high recovery is where the peer worker supports the person in starting anywhere to reach their goals. This is the Procovery. For those of you who know Procovery, it's just start anywhere. And it doesn't matter where you start. Whatever anybody does towards their goal is going to get to the goal faster. There isn't a right and wrong about what should go first and what should go last. Low recovery, the peer worker suggests what the next step towards the person goal should be. Okay, so
Ruth, I'm sorry, we had a question here. Is this
Yeah.
is this recovery always done one-on-one, or can you do it in a group?
we've done it in groups. We've done it one-on-one. It depends on how you do it. I described doing it in a group with the people from the board and care who all moved out, and the board and care operator was not happy about that, even though that was the whole goal of the contract that we got, was to create space in board and cares so people in hospitals could move in and be more independent. But you can also do it one-on-one with people. We used to, in our advanced peer specialist training, we used to do it one-on-one, and then we did it as part of the training itself, where everybody did their goals together and shared their plans together as they made them. And we found that that was much more effective, and people gave each other ideas and they could see how other people were doing it. And it's always easier if you can see somebody else doing it. Okay, any other questions? All right, so now we're moving on to self-help support groups. And by far, the most effective peer intervention of any other intervention are self-help support groups. The American Psychological Association defines a self-help support group as a voluntary, self-determining, and nonprofit gathering of people who share a condition or status. Members share mutual support and experiential knowledge to improve persons' experiences of the common situation. That's a mouthful. So we also have key components of self-help support groups, which are everyone in the group is an equal. So that means that a paid peer staff person is not running the group because they're not equal. If they're participating as the leader and they're getting paid to do that, then they're not an equal in the group. There's a status differentiation there. There's sharing or interaction between members, so people get a chance to talk to each other. Decisions about the group are made by the group members. There's not, it's not, so-and-so who's running that group is got a doctor's appointment that day, so they're not going to be there, so we're canceling the group. If the group gets canceled, it's because the group has made that decision, not because the leader isn't going to be there. Leadership is shared or rotated, okay? So that anybody could be the leader without, with just a little bit of experience in the group. The groups often use, and we very much recommend that they use a written document called a format to explain the rules of the meeting at each session. And having different people read different parts of the format during the meeting allows people to help one another because they read this or they read that. And that puts forward the helper therapy principle that we talked about earlier. The helper therapy principle. Hello? The helper therapy principle was actually first noticed in self-help support groups. Frank Riesman, who coined it, noticed in self-help support groups that one of the things that made them effective was was people were helping each other. Okay, and then safety and anonymity are protected so that everybody has the opportunity to know that if they share something, it's not going to be gossip elsewhere, etc. Okay, so those are the key components of self-help support groups. So we have research hot off the press. Dun, 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 dun. Okay, so we have a new, very big study showing that Alcoholics Anonymous and other 12-step programs are more effective, not equally effective, but more effective than than residential treatment programs or other treatment programs, so that the self-help support group does better than the professional types of treatment. And here's, if you want a copy of that publication, you can get that here. And our question is going to be in chat is, why do you think that attending Alcoholics Anonymous is more effective than going to an expensive drug and alcohol rehabilitation center? So let's get some thoughts on that.
And Ruth, while they're gearing up with that question, we did have one question. Do self-help support groups need to be formally registered?
Formally registered? I didn't get the rest of the question. Do self-help support groups need to be formally registered? The answer is no, they don't. At the same time, if you do register it with a program that's already out there, you're going to get more people participating, and they're going to be people in the community. So one of our very first $100,000 that we got from the Department of Mental Health was for putting people on welfare. It was back in the welfare to work era. If we put people on welfare into self-help support groups, and we did that because the study showed that if somebody on welfare had one friend who was not on welfare, that they were much more likely to be off of welfare in 5 years.
Right.
Okay, if they had one friend. So you want to mix the community in with the people that you're using, because they'll provide role models for the people who are joining the group new. Yes, what's the question?
No, so we've got some comments here. Peer
great.
camaraderie. Participants have an opportunity to help others. And here is a question. One of the things that is essential to a 12-step success is the prohibition on crosstalk. Can you explain this or comment on that?
Yeah, I've got a slide down below on that. So let me talk about it when we get there. But
Super. Another comment is because it is my choice, my group, and everyone there is in the same place or has been in the same place as me. Another comment, because it is peer run and not for profit. Let's see, support groups can result in natural supports.
Yes, absolutely.
I think the last one we have is because they're seeing people who are surviving the past where the new person is currently at.
Excellent, excellent. Okay, so the research on self-help support groups is huge. And they should be used in every mental health place. But, you know, one of the difficulties with mental health systems in general, I was once asked, you know, they asked a group of us at a training, if you could change one thing in the mental health system to make it better, what would you change? And what I said was the controlling nature of it. Because somehow people feel that they have to control people who have mental health issues, and that doesn't work. Control doesn't work. Support works. Control doesn't work. Enabling doesn't work. And this is what I call the rule of two boundaries. There are always two boundaries. If you enable someone, they're not going anywhere. If you control them, they're not going anywhere. If you support them, you've got those two boundaries. That's where you want to be. So, the research shows that self-help support groups cut the rehospitalization of mental health consumers by 50%. So just referring someone to a self-help support group will reduce their likelihood of coming back to the hospital again. It reduces the number of days spent in the hospital by 1/3, which is a huge amount of money saved. Yet we don't have funding for organizations that support self-help support groups. And we rarely refer to them. You know, one of the things that we get at SHARE from clinicians is, oh, they're not ready for a self-help support group yet. They need to be better before that. And that's just not the case. The studies show that people get better really quickly in self-help support groups. Okay, so they reduce significantly the amount of medication needed to treat mental health issues as prescribed by the psychiatrist. So in the blind study where the psychiatrist didn't know who was going to self-help and who wasn't, the people in the self-help groups got less meds than the people elsewhere because the psychiatrist saw them doing better. It moves large numbers of people out of the system into productive lives. And if we ever are going to be able to really deal with mental health in the United States, where 1 out of 5 people in their lifetime will be diagnosed with a major mental health issue, we really need to find ways to get people out of the system into recovery so that they're not taking a space that somebody who is in desperate need needs for clinical services. Participants are more likely to collaborate with clinical staff regarding taking medications. Okay, this used to say that they were more med compliant, but that's apparently not okay to say anymore. So they're likely to follow whatever the clinician asks them to do. And people think that the people in self-help groups are going to, you know, one of the things that clinicians will say to me is, oh, but then they'll start taking Laetrile or some bogus, you know, homeopathic thing because they say it works. And the fact that people look at the other people in the support group and they see who's doing well and who's not, and the people doing well, by and large, are following what their clinicians have asked them to do. One of the things that I have also done, one of the reasons they gave me this practice and research thing, was that I tell researchers what to study because I see it in a self-help support group already happening, and then it passes on to the researchers who writes a grant for that. And lo and behold, they are able to show that it actually works using all of the science involved. But we have that lived experience of what works and passing that to researchers, because the self-help support groups, people are there looking for what works. They're not looking for what doesn't work, and they will notice. Okay. Effects are realized in weeks and sustained for years. So very quickly people get better and they stay better when they're in self-help support groups. self-help support groups reduce drug and alcohol abuse. They also reduce demands on clinicians' time. So people aren't calling the clinicians all the time because they've got somebody else to talk to about what's going on with them. And they're better able to ask the clinician what they need to know from the clinician, because they're getting the social support that they need in their support group. I mean, the American Medical Association did a study of doctors and found that a third of all visits to doctors were for psychosocial reasons. The person's coming and saying, my arthritis really hurts and I can't deal with it any longer. And the doctor's already done everything they can. Well, if they go to the support group and they share that their arthritis really hurts, somebody else in that support group is going to share that theirs hurts too. And they're no longer alone. And we saw that disclosing up above reduced aches and pains in people. It's like when I find somebody who's going through what I'm going through, it really is healing. Okay, they increase empowerment. They provide community support, which is the expected reason that people in developing countries recover from schizophrenia at 3 times the rate. It's not, this slide is wrong. It's 3 times the rate that they do in developed countries. Somebody changed it because they felt that nobody would believe it. But the US, the World Health Organization has done a study on schizophrenia that started like 60 years ago and following all of these people across the world with schizophrenia. And what they found is that after 25 years, 30% of people who were diagnosed with schizophrenia in the United States, oh, maybe it is twice. I'm just not doing my math right. Sorry, it's twice. 30% of people in the United States diagnosed with schizophrenia have no symptoms of schizophrenia at all after 2 years, okay? So it disappears altogether in 30% of the people. In India, that number is 67%, okay? 67% of people with schizophrenia have no other symptom of schizophrenia within 2 years, after 2 years. That's huge. And the difference is, in the United States, we stigmatize people with schizophrenia. But in India, if you have schizophrenia, it means that
Eu também estou trabalhando,
it means that God talked to you. And so when God talks to you, you're special. So in the US, I get placed behind the pillar at the wedding, at the family wedding. Whereas in India, everybody with schizophrenia gets put at the head table because they bring good luck to the bride and groom, okay, to the marriage. So that's a really great study. And we have a similar study on bipolar in Canada, where they found that the only thing that made a difference between somebody with bipolar who was disabled and somebody who had bipolar who was working and self-supporting was tangible social support, whether or not they had social support around them. And it didn't matter what medication they took, what doctor they had, whether they took their medication or not, none of those things made a difference. The only thing that made a difference was whether they had tangible social support. Okay, so self-help support group provide mentoring opportunities that improve the outcomes for both the mentor and the person being mentored. That's the helper therapy again. They reduce criminal behavior. They increase family resources and reduce family stress. So getting family members into a support group makes a big difference to family members. So it's really important to get them connected to NAMI or United Parents Alliance or other family support groups. they increase consumer satisfaction. In fact, the Consumer Reports did a study on mental health, and they found that self-help support groups had the highest consumer satisfaction of any mental health intervention in the United States. So as we go to more competition in mental health, this is a way to increase your consumer satisfaction, get people into self-help support groups. And finally, the research shows that self-help support groups are underutilized by clinicians because of incorrect preconceived ideas about self-help and the lack of professional training on self-help. And okay, so there's a lot of research on self-help that it works. So the key question is, are you or your peer worker attending self-help support groups and using the lived experience with them to give the benefit of them to others? Because just referring somebody doesn't get somebody to a support group. So the best practice for referring somebody to a support group is having them talk to somebody who goes to that group. And that will get them to the support group. In fact, I love the studies where the academics, my father was a professor at Yale, so I love the studies where the academics find the exact opposite of what they wanted to find. And so they were trying to figure out how to get people to go to self-help support groups. And what they did was they gave a flyer with a phone number on it. The clinician gave a flyer with a phone number on it after recommending the person go to the support group in one. That was the control group. And then the intervention group was that they called the number on the, that the clinician called the number on the flyer and handed the phone over to the person running, you know, the person who was the contact person for that meeting. And what they found is after 2 weeks, 100% of the people who had talked to somebody went to the support group, and 0 who got the flyer had gone to the support group. And this was a test of the protocol for the study. So they lost their NIH funding for the study because they had already proved when 100% versus 0, they'd already proved that it worked and they didn't need to spend the rest of the money. So they lost their funding, which is a very sad thing, but it tells you how to do the referral by actually getting somebody on the phone who goes to that group and having them talk to somebody who goes. So if you go yourself, that works. If somebody else in your agency goes, often there's a phone number to talk to somebody beforehand, and you can arrange to have them available during a particular time so that the person can talk to that person and end up at the self-help support group. Because this is what's really going to make a difference. This is why we started SHARE back in 1991, was because this worked. You know, this worked, and we needed everybody to know about it. Okay. All right, so there are tons of different support groups, and it's different strokes for different folks, so that if you don't like 12-step, for addiction, there's Smart Recovery, there's secular organizations for sobriety, there's Free in One Recovery if you want something that's more Jesus-oriented. There's, what else do we have? We have moderation management if you don't want to quit drinking yet. And people misunderstand moderation management in that they don't realize that it's a support group for people in denial about their alcoholism. So, if you put up a sign saying support group for people in denial about their alcoholism, nobody would come, right? Whereas if you put up a sign saying moderation management, we're going to help you cut down on your on your drinking, what happens is they go to the support group and it's very clear that you're not allowed in the group if you're an alcoholic. And little by little, they go around the room and determine that everybody in the group is an alcoholic. And then they realize that everybody thinks they're an alcoholic too, at which point they go to another program. And this just makes it faster for them to get to an abstinent program. So there's also
Recovery Dharma.
Salami. Yes, right. Recovery Dharma there. Thank you, Painice. Recovery Dharma for Buddhists. There's stuff for Muslims. There's stuff for people who don't want to share their personal business. There's all sorts of different groups. And in Los Angeles, we have 12,000 support groups in Los Angeles. Cher keeps track of them. And there are 750 different groups for all different sorts of things. They work best when the worldview of the person is matched with the group with a similar worldview. So if somebody believes in God, then 12-step is fine. If they don't believe in God, you need to go to secular organizations for sobriety or smart recovery, or even Women for Sobriety as a different place to do that. Oh yeah, that's our next thing, okay? And there's Refuge Recovery, except that's different than Recovery Dharma. So there are lots of different groups. What's great about a support group is there's no need to make an appointment or call beforehand. You just show up on the day and the time of the meeting and it's fine. Cher at the moment is running groups all day, every day on Zoom. So if you don't have groups in your area and want to participate, please just go to our website and you can participate in any of our Zoom meetings with all the different sorts of things. The mental health groups that are really great, Recovery International is by far the most effective mental health group that people can go to. But there's also Emotions Anonymous if you want a more spiritual way of doing stuff. And there's some others, there's Depression and Bipolar Support Alliance. These are all good groups for mental health. Groups that have tools are better than groups that don't. Groups with a written format are better than groups that don't. They're available in many languages. It's easy to start a group in language, so it's easy to find groups in lots of different languages. Most groups ask for a small donation between $1 and $5, but nobody's turned away for lack of funds. And we recommend that people try a group 6 times before you decide if it's working for you, because support groups work so differently than a classroom setup or anything like that. So, so that's important as well. Oh dear, I'm running.
So Ruth, we're approaching the 2:15 mark, but there is a question.
Yes.
What is the role of a psychologist in a self-help group?
Okay, the psychologist's role is to provide tools for getting better to the group. There's no role inside the group. The role is to refer people and to provide evidence-based tools that people can use in the group, that they can become part of their literature. That's the role of a psychiatrist. So I'm going to skip quickly to peer bridging. Peer bridging is supporting a person in moving from one situation to another by a peer with a similar experience. So that's the inpatient to outpatient, homeless to housed, inmate to community. And we'll skip why do people go back. The peer bridgers are going to use all of the tools that we talked about. It's ideal if they get to know the people they're bridging before the new situation. They get to normalize people's fears, concerns, and feelings by disclosing their similar lived experiences. They connect people with self-help support groups. They use recovery planning. They use the helper therapy principle, and they serve as a support and a role model. Peer bridgers reduce rehospitalization by 50%. They reduce ER use in favor of outpatient services. They succeed in getting 60% of people going to self-help support groups, which of course reduces the cost of treatment and stuff like that. And the key question is the peer bridger empowering the person served and walking together as the person makes their own decision in moving from one situation to another? And are they using the other evidence-based practices for peer services? Okay, and you'll get all of these when you get to the thing, and that's the end. So if there are any questions, I'm happy to stay and answer questions and whatever else. And here we are. I've got 2:14. There's 2:15. So
Brilliant.
please.
Everyone can unmute if you'd like.
And we can talk. And I get to see that now. Thank you, Shannon.
I have a quick question for you. You're doing virtual meetings right now. How are your peers getting access to smartphones and computers? Most of my folks don't have the resources to own smartphones and computers. So how are they getting to the virtual groups that you're running?
Okay, so most everybody has a phone of some sort, so they may not be able to see people in the meeting, but they can participate by a conference phone. So that's helpful. Other people, you know, it's hard if you're at home without any device at all. And in that case, our phone lines are open for people to call us to get peer support directly.
Okay, so do you guys run a hotline?
We don't run a hotline, but at the moment we're taking peer support calls from 7:30 in the morning until 10 p.m. at night, 7 days a week.
Okay, that's great.
I mean, we do have warm lines elsewhere in the county that other groups do. We try not to. I mean, we try to do everything self-help support groups because that's what made a huge difference in our recoveries. And so warm lines are, you know, they refer to us all the time. We refer to them, but we don't run those.
Got it. Okay, thank you.
Oh, hi, this is Megan O'Brien. I'm with the Mental Health Association of San Francisco, and if you did want 100% peer run warm line, we have one that is 24/7 run.
That's right, and you guys helped sponsor our Western Recovery Conference, and there's now yes, and we, I don't know that we have a link up to you yet on the website, but we will shortly. I mean, we're having to redo our whole website, and
we feel you.
The pandemic. So
Yeah, and I could
we'll get it there soon.
Yeah, and I should just say that we are sending quite a few of our students over to the warm line as interns.
Oh my gosh, that is wonderful. I'm so happy to hear that. That's actually where I started off as a part-time worker, and now I'm a director. So It's so cool to see it like manifest.
Give our best to Peter.
Oh, I will give my best to Peter. Take care. Thank you so much for this great presentation.
You're welcome. Any other questions? We can also just unmute and chat.
Hi, everyone. This is Shannon.
Hi, Shannon.
You guys did great. This was good information.
Well, thank you. We want to do more with Riverside.